Welcome, everyone, and thank you for joining our e-seminar today on TCD uses in continuous monitoring during carotid endarterectomy surgery. My name is Katie Bullrath, and I'm the TCD clinical specialist with Natus Medical. I'm proud to be hosting today's session in conjunction with our education team. In a moment, I'm going to introduce you to our speaker and presenter, Donna Lee Davis, but first, I want to go over a few housekeeping items. During the presentation, I encourage you to write down any questions you may have for Donna Lee using the WebEx chat box to either myself or the WebEx host. I will be moderating all of the questions at the end of the session after a brief pause. At this point, I'd like to introduce our speaker. I've known Donna Lee Davis for many years now and have the greatest respect for her as a clinical nurse specialist as well as a TCD ultrasonographer with vast clinical TCD knowledge and experience. Donna Lee began her career in TCD in 1986. She then worked for 12 years as the director of the Cerebrovascular Laboratory at the Cleveland Clinic. I had the privilege of working with Donna Lee for a number of years after that when she was a TCD clinical specialist with Nicolay Biomedical. Currently, she is the director of her own education company, TCD Education. Donna Lee has earned her stellar reputation as a TCD expert, having presented multiple talks on TCD at conferences and seminars and specialty courses. She's well published and has many poster presentations, both domestically and internationally. She's been presenting periodically since 2014 at our Natus TCD educational series, speaking on such topics as use of TCD in patients with sickle cell disease, TCD collateral flow patterns, and monitoring for emboli during PFO or bubble studies. She's always met with enthusiasm by the audience, and we get great surveys when she speaks. We are proud to welcome Donna Lee today as she educates us on TCD monitoring during carotid endarterectomy. Welcome, Donna Lee. I'm going to hand the presentation over to you now.
Thank you, Katie. I appreciate that really nice introduction. I am going to now share the screen so that you can all see the presentation that I'm going to be giving. Okay. I'm going to talk today about transcranial Doppler in the OR setting, specifically for carotid endarterectomy. During the talk, I'm going to be using the oscillate simulator. It's a hemodynamic simulator that will allow me to demonstrate collateral flow patterns and what will happen in the operating room if you don't have these bridges, so to speak, in place. So carotid endarterectomy is a surgical procedure. Well, endarterectomy per se, period, is a surgical procedure to remove atherosclerotic plaque from an arterial wall lining. During an endarterectomy, this is showing you, and I hope you can all see my little pointer here, what they do. The surgeon will go in, they'll scrub skin surface first, then they will make an incision and dissect down until they isolate the three vessels. They'll isolate the common carotid artery here, the internal carotid, and the external carotid. And they'll put these little loops around to identify each vessel. And then when they're ready to shut off flow to the brain, they will literally clamp off the external here. You see the little clamps there, and then they will use these ligators, they call them ligators, to clamp off the internal and the common and the internal. But first, most surgeons will put a shunt in. This is an example of a shunt here. This is to bleed into any air. Maybe sometimes we'll see some air molecules coming through. They'll open this up and let the air come out and close it back up. But you can see where the ligations here don't literally clamp the vessel like this because they don't want to, these are plastic, so they're very, very soft. They don't want to completely impede flow, so they use the ligators to secure these without impeding the flow. So it's in the proximal or the distal common and the proximal internal carotid. So this whole area here where they're going to be operating on is essentially bloodless. So they can go in and clean all this stuff out without, and there's still flow then going to the brain. So they scoop this out. It's kind of like they use a it looks like a duck bill. It's a very, very it's a tool that will take this plaque out without damaging the lumen of the vessel, the intima of the vessel. And then what do? They will, before they restore flow to the brain up here, they'll back bleed into the external. So they'll open this up and send flow to the external. Why do they do that? Well, because if there's any little tiny microscopic debris left in this area that they weren't able to see, it's going to go out into the face, and it's not going to go to the brain and cause damage to the brain itself. So everybody throughout the world back bleeds first into the external before they restore flow to the internal, which leads directly to the brain. Okay, so let's talk about collateral flow patterns. Three collateral flow or bridges that we have, patterns that will develop. Now, remember, these things don't develop unless we've got a carotid occlusion or near occlusion. Normally, our bridges, normally the communicating arteries, they're dysfunctional. People think that they are automatically huge. They become bigger only when there's disease in the neck. Okay, normally they're very, very passive, they're dysfunctional, they do nothing. They sag, they're very tiny. But when the brain senses there's disease proximal to the brain, they start to dilate up. We have one anterior communicating artery, which is right above our nose. We have two posterior communicating arteries, and we also have an ophthalmic artery to external carotid artery pathway, which we'll talk about in a few minutes. Okay, so again, I'm going to be using the oscillate simulator to demonstrate these pathways for you. So let's minimize this and let's use our simulator here. Get rid of this dude. This is here a cerebral blood flow study that's going to show you, right now we've got 36, 44, it's showing you right to left. Now, why is there a difference on this side? Because I have in here a 90% occlusion. Now, I did that purposely to show you that even though there's 90% occlusion here, the flow still looks pretty good. It's like, okay, we're not going to have a stroke. Why is that? The reason for that is because these bridges here, here's your little ACOM. This is the ACOM on the simulator. And these two PCOMs, it's better to look on this one, you can see them. But you see how very small they are. They're very hair-like. You can't see them real well on the simulator. Very, very small. But it's telling us the bridges are all open so the brain, you know, how many times do we see a patient coming in, they're going to have a heart surgery, we're doing a carotid, we're going to do a carotid just to check them out pre-op. And you find a carotid occlusion. It's like, well, ma'am, did you have a stroke before? And, you know, he or she will say, well, I was dizzy that one day, but I've never had a stroke. The reason for that is because the brain was, the collateral bridges were protecting the brain. So this occluded off, and you see nothing happened to the brain as far as hypoperfusion. The bridges are protectors, okay? So let's open that back up. And let's now let's see what happens here. Let's increase our depth. And what do we have here? We have Mountains on mountains, right? We talked about this when we had our collateral flow lecture. The anterior cerebral artery should be going away from the probe, but instead it's coming towards us. Here's your middle cerebral artery. The anterior cerebral artery should be going this way, right, feeding the frontal lobe. But instead, we've got flow coming across the bridge here, coming towards the probe to protect the left hemisphere here. So this is reverse ACA, showing that you have a good anterior communicating artery. So what are we going to see in the PCA? In the posterior cerebral artery, let's look at the normal one first. PCA is normally in the 30s, 40s, it's low, but look at the side where the almost occlusion is. We've got flows of almost 100. So we know that the bridge in the back here is sending flow to the middle. We know that the anterior cerebral artery is reversed, so we're getting reverse flow from the other side to protect the brain. Ophthalmic artery, let's look at it. So, let me be up here. So here's the ophthalmic on the normal side. Here's the ophthalmic. I'm going to wait till this recycles. It's saying turn that power down. Okay, so here you see we have a reverse ophthalmic. This is because we have face-to-eye collateral. The external carotid artery has anastomosed two vessels of the ophthalmic and created a bridge supplying blood to the middle cerebral, okay? All right, so let's simulate what's going to happen if we have the surgeon's going to occlude off this vessel to clean it out. So they're going to occlude off this common and the internal and the external. So they're clamping off all three of these vessels. So they're going to shut flow off, and they want to see what the collateral flow patterns are. So if we clamp that off, you see we're pretty good. Nothing really happened. Okay, so let's now pretend like we don't have, an ACA. Okay, right away we start losing our flows. But now the surgeon is saying, okay, now I've got to, and they always test clamp. They're going to test to make sure what the patient's doing. So let's glue it off here. And you see our flows drop some more, but we're still not in the danger zone. So the patient is not having a stroke. So they can still get away with not shunting and doing their endarterectomy. All right, so let's change the scenario, and this happens in 5% of people where you have no bridges. The PCOM's missing and the ACA's missing. The ACOM's missing, excuse me. So right away we're saying, okay, we're going to have a stroke. The ophthalmic artery to external carotid artery is not able to keep up. So if we occlude here to clean these vessels out, you see we literally have no flow. And these people are going to have a stroke. These people have to have a shunt in. Now this scenario happens in 5% of people, because 5% of people do not have bridges. Luckily, 85% of us, or 95% of us, excuse me, have competent bridges here. So let's make them normal here. And you can see how our flows are. So this is why people will occlude their carotid artery and never have symptoms. It's because we've got good bridges, we have good collateral flow patterns. Okay, so let's minimize him again, and let's go back to our lecture here. Okay, so stroke following endarterectomy happens in 3 to 5% of people. So if you're scheduled for a carotid, the doctor's going to tell you, I'm going to do this, and we're going to get all that. We're going to get that plaque out of your neck, and I just want you to know before going in, less than 5%, you have a less than 5% chance you might have a stroke. The stroke is going to be caused by hypoperfusion, which, what does that mean? It means that your brain is not getting flow because you don't have good bridges. Incompetent collateral pathways. The other things that will cause a stroke is microemboli. These lesions in the neck can be very, very ugly. As we go to clean them out, many times these little emboli go up into the brain and break off before we can get this plaque out in one piece and cause a stroke. Reocclusion, which we're going to talk about later on, is from a flat dissection where a little portion of the vessel wall will come back down and reocclude the vessel. Now, the final complication that will cause a stroke following endarterectomy is not hypoperfusion, where we have really poor flow, but now we have hyperperfusion, which is an increase in blood flow velocity associated with dysautoregulation. So your brain, your vessels in your brain are maximally dilated. They are so used to being starved that they're as big as they can get. I can't get any bigger, and I'm okay with that. But now you go down and you clean out the vessels in my neck, and now I have all this flow going up there, and I can't get any smaller. So you get overperfusion, which leads to little hemorrhages, dysautoregulation, and can lead to stroke. So it's a definite complication here. Okay, so let's talk about emboli first. We all know from past lectures that other people have given, not only myself, but emboli can be identified with TCD. You're bouncing off of moving red blood cells. As the cells are going past the ultrasound beam, we're able to get a measurement of flow velocity, how fast they're going in there. If you have an embolus that's going past the sample volume, it's going to be reflected differently. It's a different composition than a red blood cell. It's at a different rate of speed than a red blood cell. So the Doppler identifies it as being foreign. So transcranial Doppler is very sensitive in identifying emboli. So that's number one. Number two is the surgeon will know immediately what the status is of the collateral flow. So when he or she clamps that common and the internal, and they're going to clean all that out, you will know if the bridges are open or not. And you can tell the surgeon, I've got good flow or I don't have good flow. And if I don't have good flow, you might have to put a shunt in. It will also detect complications before the patient has symptoms. So we're going to talk about a kinked shunt, the hyperemia, the hyperperfusion. You can tell them, my flows are like 3 times what they were before we started this procedure. So transcranial Doppler is an immediate assessment of what's going on in the brain. It's not comparable to EEG. EEG will give you an electrical evaluation of the transmission, but it will not give you a hemodynamic evaluation. All right, so let's talk about how we do this. So people don't come in anymore the day before they have surgery. It just doesn't happen. They come in the day of surgery. You be here at 4 o'clock in the morning because you're scheduled for surgery at 7. You're going to go to the holding area. They're going to get you ready, and then at 7 o'clock or 6:30 or 6:15, you're going to be in the OR, and me as a surgeon, I'll be there at 7, and we'll get this done. You're going to want to see the patient in the holding area. So, you're going to have to be there early, 6:30 before they leave to go into the OR. You're going to want to do a transcranial. Check and see, number one, do they have windows? Am I going to waste my time in the operating room doing an evaluation? No. Do this in the holding area. Do a complete study, because remember, you get paid for not only a complete study, but you get paid for being in the OR as well. So if they do have a window, you want to mark the skin surface. I'm sorry if you hear the thunder. We're getting a really bad storm here in Pittsburgh. So after you do your complete study, you want to mark the skin surface so that when you're in the operating room, you know where to put that probe. You want to obtain a baseline. What are they before they're asleep? What's their walkie-talkie baseline transcranial Doppler? You apply the fixation device following induction. You don't want to put the fixation device on the head in the holding area. And I'll tell you why that is. The reason for that is that when anesthesia puts an endotracheal tube down the patient's throat, they hyperextend the head. And your device may get in their way. So you never want to interfere with induction. So you want to try to put the fixation device on after the patient has the endotracheal tube in, after anesthesia is through with everything they need to do. Now, remember that velocities will drop. You're going to get a baseline in the holding area, and then in the operating room, you're going to put you're going to put the Doppler back on, and you're going to notice the velocities are lower. The patient is asleep. Velocities normally drop about 30% after the patient is asleep. So expect that. You're not going to have flows of 60 that you had in the holding area in the operating room after the patient's asleep. Velocities will drop at least 30%. Okay, so again, identify presence of your sonolucent window, mark your skin surface. You want to try to stay away from this window back here. I know everybody loves it because it's easy to use. There's always a window there. But remember, the ear here gets in the way of that probe, the holder. You know, the probe's going to be in an eyeball. So you want to try to always use a medial window when you're doing this. All right, so this is a fixation device. This is with the Nicolay product line. But I can tell you from working with all these companies, they're all the same. So basically, they're like a surgeon's headlight. So you want to make sure, and Katie and I have done a monitoring webinar, and you may have attended it. You want to make sure that this is higher on the forehead and your back strap is low. And I don't care which company you use. There's just tricks to putting this headband on and be successful with it, because they're definitely not user friendly. Okay, so this is Katie Vollrath.
First thing I wanted to make sure that
I hope you can all hear it.
Possibly it's altered like a big ball cap. I have a special shot. I'm applying it first, making sure that this goes below the occiput or the ilium, and then this lines up with his nose. Okay, now I'm going to tighten this. Sean, are you doing all right? Okay. The next thing then is to make certain that you tighten this black Velcro strap, and we have the headgear properly placed on Sean.
Okay, we're going to go on. Katie's going to do another little.
Some gel on my transducer, which is threaded into the transducer holder. When you apply this, you want to make sure that the blue knob is facing towards the front. So I'm going to just place this. This can move back and forth across the window. I'm going to place this on Sean, and I'm going to just lightly tighten this while I begin my exam. I'm going to loosen this up a little bit while I find the signal. and I'm going to tighten the blue knob. The blue knob holds the angle, and the black knob holds the actual position along the transfemoral window where I found the stigma.
Okay, thank you, Katie, for helping us there. All right, so let's talk about emboli with endarterectomy. So this is an actual specimen that we took out of a patient. When they opened this up, this looked like red tapioca pudding. It was really, really bad. But you can see all the ulcerations in here and how ugly this plaque is. So these plaques are very, very labile. Surface ulcerations, they can literally have thrombus in there. So I always recommend for people, and you guys know what microemboli look like, sound like. This isn't a video of one, but it's just a picture, but it's not an audio of one. But you want to, I want to go back to this. So you want to, when they're scrubbing skin surface, you want to monitor these people, like evaluate them in the holding area. You're in the operating room, anesthesia has them asleep now. You say to anesthesia, because you've got to be friends with these people, can I put the headband on? Will you hold the head while I slip this around their, over the crown? And they'll help you all the time. Find the window again, because you have it marked. Get out of their way. These cords are long enough on these probes that you can be away from anesthesia, not in their space, but still be in their space if you need to be. So you want to listen for emboli from the very beginning. You don't want to put it on and say, call me when they're ready to clamp. And I'm going to tell you why. These plaques, because they can be very labile, you can hear emboli even when the scrub nurse is scrubbing the neck. Okay, the surgeon's out there washing his hands, getting ready to do the procedure. The nurse is in there prepping the skin. If I hear emboli being proliferated just from a skin scrub, I tell the nurse or tell the scrub technician, I'm hearing emboli. I just want you to know that the plaque may be very labile. When the surgeon comes in, I say to the surgeon, I was hearing emboli, just for your information, just during skin scrub. And the surgeon is going to be very careful with dissection down into isolating these vessels. So you need to let the surgeon know if you're hearing emboli right away, because this is important for them. You don't want the patient to have a stroke from emboli before they've even done the procedure. So it's very important to monitor the whole time once you're committed to being in there. All right, so now what are they going to do? They're going to go in and they're going to cross clamp. So this is a slide. I'm sorry it's black and white, but it's showing you how they're going to ligate off the common and the internal and external here, and they're going to shunt. Some surgeons will shunt everybody. Oops, sorry. Some surgeons will shunt everybody. Other surgeons will selectively shunt. So they only shunt if they have to. Other surgeons, they'll shunt everybody. So they'll bypass this plaque, put the shunt proximal and distal to the area where they're working. And I have some color pictures showing you this. So if the patient has good collateral flow, this is what you're going to see. This is an angio showing the crossover flow here. Okay, so it's showing that the one side of the brain here is protecting the other side. And we have flow, so here's before they clamp and this is when they clamp. So we still have flow there. Now, if you don't have good collateral, and again, I like to use this black and white because it's a little bit more dramatic, but you can see where we have flow here, and then where they cross clamp, they're going to clamp off to clean. We have no collateral here. Even though this is a mean of 28, that's measuring this. This is measuring 0 because there's nothing there. And you can see by the angiogram, there's no crossover here. So this is a demonstration of definite incompetent collateral. Now, this is the tube that they use. This is a shunt here. These are plastic. They become they're soft to begin with. A lot of them now have little ridges in them to make them a little stiffer. But once the warm blood gets in there, they're very soft, and they can kink off. So you got to remember that even though the surgeon thinks they're protecting the brain, sometimes these shunts will kink off, and they have no idea of knowing it. And I'm going to show you some pictures of that. So the shunt will restore flow to the hemisphere and bypass the plaque. Okay, and this is showing you the different tools that they use here. So this is an actual endarterectomy, and for those of you who are queasy, I apologize. But so we've got a shunt in the proximal and the distal. So this is in the common, and this is in the internal. And you can see here the red, and it's bypassing the plaque that's in here. Now the surgeon will take this tube and they'll move it over here, they'll move it back here, just to so that they can pull this plaque out all in one piece. Now keep in mind that this tube is going to be red. It's going to have blood in it regardless of if it's kinked or not. So if up here I move this from here to here and this thing kinks off, the surgeon's not going to know it because you still have blood in this shunt. Okay, so plaque dissection is the purpose of repositioning the shunt, and it can result in some kinking. And again, the surgeon is unaware. So this is showing you how they took that shunt that I showed you before, and they're moving it way down here so they can pull this plaque out all in one piece. They try to, they don't want to take this plaque out piecemeal. They want it all out in one piece if they can. They don't want to have any little shells of plaque sitting up there inside the vessel. They have a little tool that looks like a duckbill that they kind of scoop these things out with. Okay, so how do you detect a kinked shunt? Well, you're going to have flow, and then during the operation, you had good flow, and now all of a sudden you lose it again. You got to tell the surgeon, my flows went from 60, now I'm down to 20. And the surgeon will say, well, okay, hold on, and then they'll move the shunt a little bit and say, is that better? And you can say yes or no. So you're going to have a decrease in mean flow velocities when you've got a kinked shunt. This is what the plaque looks like when they dissect this out. They're very, very ugly. Definitely, you know, too many Big Macs. Okay, so post-plaque dissection. So once they get this plaque out of there, they're going to do two things. They're going to primary close, which means they're going to literally sew up the vessel, sew up the vessel that they've opened up and cleaned it out, and that's it. Other surgeons will patch graft. Now, they patch graft. Some surgeons patch graft everybody. Other surgeons will only patch graft if the vessel is very small. You know, if you've got a small little lady, she's got tiny vessels, they'll patch graft. Because remember, when you open the vessel up, you make an incision, you take it out. If you primary close it, so if you just sew it back up, it's going to take away some of the diameter of the vessel. So if they've got a small vessel to begin with, they're going to say, well, let's just put a patch in there and, you know, make it a little bit bigger. Now, patch graft closures can be from an artificial graft, which they come prepackaged and they just, you know, use them. Other grafts can be from a vein. So they'll take a vein, usually from a leg, if they take a vein graft. And so you have not only an incision on your leg, but now you have an incision in your neck. It just depends on where the surgeon's been trained. Okay, so this is a primary closure. So you see here, they sewed here, this is the shunt here. So this shunt's been in the whole time, and they sew this up here, they sew this up here, and then they'll use this is called a bulldog, and they'll partially occlude the vessel just so they can take the shunt out and then stitch up the final vessel, the final portion. So that's a primary closure. This is what a patch graft looks like. This is what it looks like, whether it's vein or it's artificial. This is what they look like. I can tell you that vein grafts do not embolize as much once you restore flow than a artificial graft does. The artificial graft has little ridges in it, and a lot of times the emboli will migrate in there and sit in there, and the eddy currents will cause some emboli. You know, a lot of doctors will say, well, now that you've monitored in the OR, I want you to go into the recovery room and monitor for an hour. And you'll hear ongoing emboli with a lot of patch grafting, where you don't have it with vein or just a primary closure, okay? All right, so this is what a normal flow restoration looks like. So you unclamp, and you've got usually an embolus or two. That's kind of normal, especially if you're using a shunt. And then you have a flow that just kind of, you get a little bit of hyperemia. It's almost like if you press on your neck and you're looking at your middle, and then you release it, you've got a little bit of high flows for a few seconds, and then it quickly resolves back down. That's called a little hyperemia, and that's normal. It resolves pretty quickly. Now, hyperemia is a complication of endarterectomy. So if, when they restore flow, you don't get that decrease in flow velocity, but you have an increase in flow velocity of greater than 50% from the baseline. And I'm not talking baseline walkie-talkie in the holding area. I'm talking your baseline now in the OR. If it's greater than 50%, so my flows were 60 following anesthesia, or they were, let's say they were 40-ish following anesthesia, and my flows now post-endarterectomy are 100, that's hyperemia. That's not a good velocity we want to have. Hyperemia normally resolves within minutes. It does not sustain. So, you know, I'm going to say within a minute is what it normally resolves, but the literature says within minutes. So we're talking 1 to 2 minutes. You should have flows back to what they were during the operation. Now, a sustained hyperemia, it can last greater than 5 minutes. And what happens is the vessel is so dilated, it loses the ability to autoregulate. So it's not able to say, okay, I don't need to be this big anymore, but I can't get any smaller. I can't get back to normal. That's dysautoregulation. And this is an example of that. You can see where the emboli are here. We unclamped. You can see how low my flows were. And we've got this high flows with the emboli. This is some emboli here. Okay? So if you have sustained hyperemia, you want to let somebody know about it. You don't want to just sit there and say, well, it's hyperemia. You got to let somebody know. Remember that autoregulation is the ability of our blood vessels, of our brain, to maintain constant flow despite changes in pressure. So your vessels should be able to dilate and constrict during changes. If they don't do this, they're vasoparalyzed, and they can't do it. So the first thing I do, if I have a sustained hyperemia, I let anesthesia know. So I'm in their arena already. We've now become friends. I bought them donuts before I went into the OR, because you're in their space. So, and trust me, anesthesia ends up being really, really interested in TCD. They don't really like the fact that you're there, but the surgeon says, I don't care, I want this monitoring. But anesthesia really, really, they love TCD. And you say to anesthesia, well, what's your blood pressure? Because remember, during the cross-clamping, when the surgeon's operating to take this plaque out of the neck, anesthesia is going to increase blood pressure to maintain flow to the brain. So they pharmacologically increase blood pressure. And then when the surgeon says, okay, I'm going to be unclamping, they tell anesthesia, I'm going to unclamp here, we're going to restore flow, we're good, we're ready to close up. Anesthesia will start dropping their blood pressure down to where it was normally. Now, if they have trouble doing that, you're going to have high flows, because remember, it's all equated. Blood pressure is equivocal to the flows in the brain. So I always say to anesthesia, well, what are your flows? Because my flows are real high right now. What's the blood pressure? And they'll say, well, really, my blood pressure keeps increasing, and I can't get it down. So that would say, okay, that's why my flows are high. But if anesthesia says my blood flows or my blood pressure is what it was pre-op, then you've got to say, well, I got high flows here, and you got to tell the surgeon. You got to say, you know, my flows are very, very high. Now, what will the surgeon do about it? You know, if they're high due to anesthesia, the anesthesiologist will decrease blood pressure. But if their blood pressure is already down, you have got to let the surgeon know, and they'll put a little bulldog on there. They'll do like they did with the primary closure, and they'll partially re-occlude that vessel to try and calm the vessel down. This adds about 20 more minutes to the case, but you know, it's better than having a hyperperfusion syndrome. You know, sometimes people will complain of headaches after they have the procedure. It's all due to like a lot of flow up there in the brain. So transcranial Doppler is very important in monitoring complications. Complications can occur even before the surgeon's in the room, and we talked about that already, but let's think about this. So emboli during skin prep and vessel, dissection. It alerts the surgeon that the plaque is very labial, and people will change their technique. The scrub nurse won't press so hard on the neck. The surgeon's going to be very careful with their vessel dissection. Okay, kinked shunt. So if the surgeon has moved the shunt here, and you can see where we have the red here, they've moved it around to like kind of scoop the rest of this plaque out, and you say to the surgeon, well, I now have lower flows, what's going on? I mean, and they'll say, well, hold on a minute, I moved this shunt a little bit, and they'll move the shunt back or reposition the shunt, and then you can say, okay, yeah, now I got my flows back. So it's good to have a one-on-one with your surgeon, and trust me, usually surgeons that monitor with TCD, they want you there for a reason. Your reason is to keep monitoring the brain while they're working on the neck. So surgeons are very, very receptive to our input. So don't be intimidated by them. And anesthesia, again, will become your very, very good friend. Okay, so the other complication is a sustained hyperemia. So, when the surgeon restores flow to the brain, you talk to anesthesia. What's your blood pressure now? I mean, my flows are huge. And they'll say, well, hold on, I'm trying to get it down, or I don't know what's wrong. Your flows are, the blood pressure is back to what it was pre-op. And so the surgeon then will apply a partial clamp to the vessel, let the patient's brain calm down a little bit and get used to having a lot of flow going up there now. Okay, Other complication that doesn't occur often, but we have to talk about, is a flap dissection. Now, this occurs at the very, very end of the procedure. It's rare to occur immediate. Okay, so that's kind of important to remember. The surgeon says, okay, I'm going to open up, we're going to restore flow, let's get out of here. It doesn't occur then. It occurs when the surgeon is ready to close the skin and they're ready to move on to the next case. So it's at the end of the procedure. You're going to have a gradual decrease in mean flow velocity and some emboli proliferation. And you've got to let people know. And this is an actual case study that I want to present to you today. This is a 54-year-old. He had a 90% carotid stenosis. We did him under general anesthesia, and he was shunted because he did not have good collateral flow pattern. Now, this is important. It was a primary closure. We did not attach graft him. So he just had the vessel just sutured up. So post-endarterectomy, you can see my flows are beautiful there. All right, so during skin closure, I'm starting to see a decrease in mean flow velocity. And I said to the anesthesiologist, I'm like, well, what's your blood pressure? And he's like, well, we're getting the pressure down back to where it should be. So I wasn't really alarmed at first. And then all of a sudden, the velocities continued to drop, and I heard emboli. This is an embolus here, right here. This is an embolus. And emboli can occur post-procedure, trust me, but I started to get a little bit concerned when the anesthesiologist said, oh, his blood pressure is really increasing. So what was happening was, and you can see here, this is a really good example. So my flows were dropping, and then you see how all of a sudden they would increase, and then they would drop off again. I would hear emboli, and then they would increase again. This is a flap dissection. So what's happening here is the surgeon tried to pull all that plaque out in one piece, but left a little shelf in there that he did not see. Now, sometimes you'll hear surgeons say, could I have a tack suture? And a tack suture is where they use a little tiny suture to attach this plaque shelf to the vessel. Okay, so they just tack this up, just like putting a hammer and nail up on the ceiling. This wasn't identified in this case, and as flow kept flowing and getting all of this blood pulled this vessel lumen down and caused what I was seeing here. So it was like this was literally flapping. And if you think about a flap, so we've got this will come back up, and then as the blood flows through here, it'll come back down, and then it'll go back up and then come back down. So that's a flap dissection. That's what it means. And this thing will literally go down and occlude the vessel. Now, again, this happens at the end of the procedure. When we do carotid ultrasound in the recovery room, this is what the surgeon is looking for. They're looking to make sure there is no flap dissection, because when you ultrasound the carotid artery post-op, you can see, is there any abnormal lumen hanging down there, okay? But with TCD, you can tell this complication at the end of the procedure. So this is what was happening with re-exploration. You see how low the velocities were, and they're now very truncated. And, you know, the surgeon, he had never seen anything like this, and neither had I. And he said, are you sure, Donnelly? And I said, well, you know, there's something wrong here, and, you know, I'm almost sure. And he said, okay, well, let's just open back up. So he opened back up. Remember, he was closing skin. So he opened back up, and sure enough, he had a huge thrombus and found the flap dissection, and he ended up putting a patch graft in there. These occur more often with primary closures and not so often with flap with patch grafting. Because remember, with patch grafts, you make the lumen bigger, and they don't have a chance to form, okay? All right, so let's talk about billing real quick, and then we're going to be through here. So there's codes now for us being paid for doing TCD in the operating room. Years ago, this was all done gratis. We would do a complete TCD and then do another complete TCD post, and we were just happy to monitor in the operating room. But now you'll get paid for a complete TCD, and you can co-report the 93892, which is emboli detection without microbubble injection. So we're not literally doing a PFO evaluation. We're looking for emboli in the operating room. So the 93892 is when there is no injection. So that you're covered then under for the carotid endarterectomy. So you have to co-report these. Now, don't forget this. It's very important. You have to do a complete study, the 93886, and you co-report it with the 93892. You cannot co-report with the limited study, of course, because limited is when you don't have temporal windows, and you just can do the vertebrobasilar and the ophthalmic or the orbital approach. Okay, so in conclusion, TCD is sensitive in emboli detection. We all know that. But in the operating room arena, during endarterectomy, it allows the surgeon to have an immediate assessment of blood flow. If we're doing EEG, you're not going to have changes until there's problems in the brain. Transcranial Doppler puts a pulse on the procedure. Immediate assessment of blood flow, it'll detect complications, and the surgeon can do something about it, or anesthesian can do something about it. It's very cost effective, and it's non-invasive. That's the big thing. And with that, we're going to finish. I'm going to hand it back over to Katie and take any questions you might have.
Okay. Donna Lee, thank you so much. We've already had some, sorry, we've already had some questions come in, and we only have about 5 minutes, maybe 6 minutes to answer questions. So, Donna Lee, the question is, can you monitor TCD and EEG at the same time together?
Good question. You can, Katie, but you have to make sure that before the EEG people get in there, the neurodiagnostic people get in there, you want to mark your temporal bone. They use a temporal lead. So they're going to put a lead on the temporal bone. You want to make sure that you secure your window first. They're going to put their lead around your window. And you put the fixation device right over top of their leads. Don't put them over that blue OR cap. You never want to put the TCD fixation device over that blue OR cap. So let them put their leads on, have your dot there, your green or your purple dot, whatever. Once they put their leads on, then you put your fixation device on, and you'll both be able to monitor no problem.
Next question is, when you've done your TCD monitoring, Donna Lee, typically how long is a case?
You know, these cases, it depends on the surgeon. I mean, like I say, I always go to the holding area. Once you're committed, once you're in the OR, these cases can last 3 hours. And if the surgeon wants you to monitor in the recovery room, which some of them do, because they're looking for emboli ongoing, and then they'll, you know, give something pharmacologically. They might even give an aspirin or something, depending on if you're having emboli or not. But, you know, you got to allow at least 4 hours is a safe window. So half of your day, half of your 8-hour day is going to be tied up.
Okay. This is probably the last question we'll take, and then we'll do our wrap-up here. You mentioned performing a baseline TCD in the prep room. What do you do if you can't find a window? How have you handled that, Donnelly?
You just don't do it. And, you know, Katie, I will not, and I did this for years. I tried to, you know, use that posterior window because it's the only window I had, the one right in front of the ear.
Yeah.
And it's failed so many times because the probe, I just couldn't get a good signal at it. And I'd end up on my hands and knees holding that probe during the procedure, and it was painful. So you want to make sure you have a good medial window. If you don't, you just have to say, I'm sorry, doctor, I can't monitor. Their skull's too thick. Don't torture yourself. This is the takeaway from that.
We do have more questions, but I'm sorry, we're really running out of time here. So, Donnelly, we do want to thank you for that lovely presentation on the many tips regarding TCD monitoring during carotid endarterectomy. Also, please note that our past TCD webinars are available on the Natus Neurology YouTube channel. Note, though, that you cannot receive CMEs for watching these videos as they're just for reference, refreshing, and education only. If you subscribe to our YouTube channel, you will receive an email notification every time we add a new webinar. So you can find us by searching Natus Neurology on YouTube. Again, thank you, everybody, for your participation, and we look forward to next time.